Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. David Carmouche from Lumeris about compassion and code, leveraging technology for personalized patient care. Let's get started. Hello, Dr. Dan.
Hey, Faisel.
And look who we have, Dr. David Carmouche. Good to see you, sir.
Hello, gentlemen. Good to be with you.
Well, I'm so excited to have you on. You've got so much experience, and especially now, I mean, the world that even I'm in now is AI is coming in everywhere. I mean, even with like case conference prep. I mean, so many different aspects, reshaping the whole experience, not only for us as primary care doctors, but for the entire care team. So let's start off with this. Do you think that we're really on the brink of care transformation, or are we still like in the more work to be done phase?
It's on my mind a lot right now. This is, transformation is going to happen here at the pace of adoption. And adoption is a human change management, emotion-filled reality, right? So I think it's going to depend on early on, do providers, specifically physicians, for sure, see value? Do they develop trust? Can they imagine a world where they delegate service to an AI agent that might interact directly with a patient outside of their line of sight, right? That's a lot of change to deal with. And maybe 3 years ago, I would have said, I think this is going to be a long putt. I think two things have changed. Number one, I think the state of primary care is rapidly deteriorating, and I think is under significant duress. And I think if you guys saw the Milbank, I think is it Milbank study on the state of primary care in America, it came out like this week. It's pretty dire, because now for the first time they show that not only is physician to 100,000 population rates kind of falling, nurse practitioners and PAs are leaving primary care. So like what's going to happen as the population ages, right? So I think the situation has become more dire. And I think with ambient listening technology that are AI supported, I think physicians maybe have moved beyond the EMR technology wave, kind of making their life a little bit worse, to kind of at least being open to the notion that some modern technologies could make their life a little bit better. So I think timing wise, we need help. We don't have enough people to do the work. There's some experience now with technology helping. And so I think we're set up maybe to have a positive conversation with folks and actually be on the cusp of real transformation here.
I'm working back at the University of Virginia now, and they turned on DAX. We have Epic, and they turned on DAX for me about 2 weeks ago. I didn't ask for it. They just said, we're giving it to you. And so the first day I just looked and it was on my phone and I started using it. And now I'm 2 weeks in and I'm like, yeah, you get to pry this out of my cold, dead hands now, because it's, I'm not typing the entire time. I'm still using the computer when I'm with the patient, but I'm using it for higher order functions. But I sort of feel like ambient AI is sort of a party trick for AI when you look at some of the other stuff that it can do. When does it start influencing our decision making? When do we get that augmented decision making that I think is going to be available with AI to help us bring the evidence right to the point of care?
Yeah, I think that's happening now. It's certainly going to happen this year. We announced a product at Lumeris at Vive in Nashville this week called Tom, which is Primary Care as a Service. It's a multi-AI agent care team member for primary care. And our vision for that includes real-time clinical decision support driven by AI. So if we understand the evidence, we understand point diabetes at ADA guidelines if you want. Theoretically, right, in real time, we should know a lot about a patient. We should understand the guidelines, and really at the point of care, for either a nurse practitioner, PA, or physician, the next best clinical action should be known and available, right? And we see that upskilling. I see that upskilling primary care providers. So I think that's there. I think on clinical diagnosis support, I think there's good evidence to say the current LLM models are really, really good. And if you've played with any of them that are commercially available, like, you put in some pretty sophisticated cases, you get a differential diagnosis that's better than most doctors are going to deliver, right? It's more comprehensive. It's pretty accurate in my mind. So I think we're there. And I think that's been needed because, the EMRs didn't do a lot to change how, like the quality of care that was delivered. They really were, more documenting and kind of digitizing healthcare transactions. And so for me, that's been it's left us a little flat. I think we've needed technology. Clearly, we would all say the pace of scientific discovery moves faster than the human brain can both process it and deploy it. And I think AI should be the solution for that. So I think we're on the cusp of that. And I think you'll see that happening this calendar year.
So what do you think the key is as a primary care provider, physician, or APP? What is going to be our role in, I think there's still a place for that human interaction. So how do we do what we do best and let the AI do what it does best?
Totally agree with you. I mean, I can't envision a world yet where we've taken humans out of the loop. I mean, I think the computing power would be there to do that. But I just don't see that being from a regulatory environment, from the FDA's perspective, the way they classify, medical devices today, you would have a hard time having that happen. I think patients aren't ready for that either, frankly. I think there's been some recent surveys, results from this month that said, adults in the United States are still more skeptical than not of directly interacting with AI. I think that'll change fairly quickly. My experience has been that it can change very quickly. So listen, I think to put physicians specifically in the right position, it really requires a bit of a redesign of the whole system. So physicians, what should we do, right? We are relationships people, compassionate people, difficult conversations, difficult diagnosis, problem solving, complex cases where there are no clear algorithmic approaches and you really need to rely on your experience as a clinician. Support for, or really probably the part of the care team that should be seeing most acute, unstructured problems. We tend to default that to, or kind of send that to the nurse practitioner, to the PA, because the physician starts their day with a full schedule. So anybody who's coming in sick is kind of being asked to be seen by an APP. In some cases, that's fine. But in other cases, that's probably not the most appropriate person on the care team to see someone with recurrent syncope and, on 8 drugs and in the hospital twice with 5 doctors. And so, I think carving out time so that clinicians can see difficult cases and do those things is important. The problem we have is an access problem and a chronic disease problem. So I think what AI can handle very well is all the prevention and wellness. Literally, everything from tailored nutritional advice and exercise advice and smoking cessation and disease state education. AI is awesome at that. And, cancer screening reminders and facilitation of scheduling of those can all be done. Chronic diseases is going to be kind of a combination of the clinical decision support tools you mentioned, Dr. Dan, and probably APP-led care supported by AI, doing inter-visit checkups on patients to kind of see how they're doing and summarizing that for a clinician and alerting care teams to when someone's getting off course and probably shouldn't wait 4 more months to have their blood pressure recheck, right? So I think a redesign of how we do chronic disease care, larger panels by virtue of doctors overseeing APPs who are supported with AI. I think that care model is in my mind probably the right care model. The challenge then becomes an economic one, and it's how do you pay for care that increasingly with AI can be done in the home without someone coming in and having a billable visit. right? So we're going to have to move in some ways, ideally away from fee for service to unlock the full potential of technology. And that means some version of primary care capitation, a subscription model, and or total cost of care cap if you're in a more sophisticated environment. I think all of that has to happen. So this is not just going to be a technology issue. I think technology plus redesign plus payment redesign gets kind of the providers, physicians doing the work that they probably need to do. Long answer, because it's a complicated problem. If it was an easy one, I think we'd have done it by now.
It's so refreshing to hear you speak. I mean, you've made a career making some pretty bold efforts to expand access to primary care. Just earlier today, this afternoon, I was talking with Dr. Dan that there's still 100 million Americans who don't have access to quality primary care. So what's the one thing that you wish like the entire industry would prioritize right now, especially with the 100 million, like a third of Americans still don't have access to quality primary care?
The ACA was an interesting legislation in that it increased insurance access to more people than ever have been covered. And yet it didn't solve that problem. I don't have an answer. I think that we have to make it a priority in this country. And that priority is probably, there's no one thing that means. That means probably workforce solutions. Maybe it's shortening the time from the time you enter college to you come out of medical school and residency to be a primary care physician. Maybe we figure out a better way to do that so there's less debt burden. Maybe we relieve debt in patients who choose care and choose to practice primary care. I think we've got to create the right financing mechanism so that all Americans can access primary care. I mean, there's no reason. We all pay for these 100 million people who don't have access to primary care because they go to the emergency room and they go to expensive places of care. And then that just gets translated into higher premiums. We're all paying for this in some ways. And so I'd like to see, universal access to primary care in some way. And with a payment model that's not fee for service. I mean, I think ultimately that's what's got to happen. And then we've got to make it more attractive. That attractiveness isn't just money. I don't know that you can throw enough money into primary care to make doctors want to do it, but you can change the prestige of the profession. You can recognize it for how important it is. It's interesting when I trained at the University of Alabama at Birmingham, and I had world-class training in internal medicine with some of the best professors in the world. And I was fortunate enough to be asked to be a chief resident and stay a fourth year and teach. And at the end of my fourth year, I chose to go into primary care. And you'd have thought I stuck a knife in the heart of the program. They were so disappointed. And that's like, and I mean, and I love the place, and I hope that they don't get mad at me for saying that publicly. But honestly, like that's part of the challenge, right? It's almost like, oh, well, why are you doing that? It's like, well, I don't know. I mean, I think probably in my career, I probably have had a bigger impact on humanity doing primary care and where that has taken my career than I ever would have been, had I been a cardiologist or which is what I would have probably done. So I don't know. I think we've got to change a lot to make this happen. So it's no one thing.
I think we all have this story of when we were medical students, somebody telling us we didn't want to go into primary care because all we would see was earaches and sore throats. And I've been practicing for, over 35 years now. And I've said it many times, I would kill for a day of earaches and sore throats. That's not what I get to see, right?
No, I totally agree.
Yeah. So I know when you were at Ochsner, you did if I recall, you did a fair amount of work around social equity and social determinants of health. How do we make sure that we bring the 100 million people, we bring them all along in health equity as we move forward? I mean, as you pointed out, we're all paying for it. Sort of like California, a lot of the homeowners insurance, after all the fires, those companies have had to declare bankruptcy. The state has had to come in and shore them up. And how did they shore them up? Well, they're going back, and all the insurance companies that didn't go out of business, they're basically having to pay for the state to pay for all those claims that the other insurers weren't paying. So we're sort of like that, right? I mean, if my neighbor can't get primary care and has to go to the emergency room, that gets at some level winds up getting passed on either through insurance premiums or taxes. And I wind up having to pay for it.
Yeah, no. So listen, I think first of all, I practiced for 15 years in the state of Louisiana, which is 49 or 50 in healthcare. So a lot of opportunities from a health equity and access and unequal access perspective. Auctioner for 8 years. You're right. We took on, while I was at Auctioner, this notion of trying to help move Louisiana from 50 to 40 by the end of 2030, and bringing a lot of partners to the table. And that activity is underway across the state. And then I was at Walmart, and that was an access into rural and underserved communities as well, and trying to leverage Walmart's position as one of the largest employers in the country, one of the largest grocer in the company, and that was a unique opportunity because we had the opportunity not just to deliver healthcare, but to deal directly with some of the social determinants of health through Walmart's reach and efforts. Again, tough question and no clear answer. I think that this is not all on the delivery system though, right? I think a lot of health equity, or what I'll just call the factors that influence health and that disadvantage some versus others, is not really a healthcare delivery problem. It's a societal problem. In other parts of the world, there's much bigger investment into social programs and safety net type programs and things that improve housing and improve access to healthy foods, et cetera. I mean, from a care delivery perspective, I think it's largely access. I mean, FQHCs there are not enough of them. Providers tend to limit Medicaid access in many cases. Medicaid financing is substandard and really makes it hard to kind of, if it was even Medicare rates, it would be helpful. So I think, the delivery system has some challenges. I think from how we're approaching that at Lumeris, in our data environment, we've purchased, I think, 2,700 consumer data points on a large proportion of Americans, and we've converted, and those consumer data points are the things that Facebook and others use to target market to us. But you can convert that, it's everything from zip code to, are you active on social media? What social media platforms? How frequently do you tweet? Do you have a car? Do you have a house note? And so from that consumer data, you can discern a lot of the kind of the social challenges that people may have, and we incorporate that into all of our predictive models and our segmenting models. And so, thinking about when you are doing population health, making sure that you are capturing that information and using it beyond just clinical characteristics to kind of identify populations who may need services is part of the responsibility, I think, of the care delivery system. The way that plays out with AI, right, is now we can have an AI agent who's doing a transitional care visit. So Faisel comes out of the hospital, an ADT feed triggers Tom, in our case, to know that the next best action is to place an conversational AI phone call to him. At the time, we also know he likely has a transportation barrier. And so the conversation is scripted unique to that. And so it's not just, hey, how are you feeling since you left the hospital? Do you understand your diagnosis? Have you filled your new prescription? Do you have any questions about your medications? Can I set up an appointment for you in the next 5 days to see Dr. Carmouche? And oh, by the way, can I help arrange transportation for that visit? That is how we have to be kind of thinking about healthcare delivery. And you only do that if your data captures the kind of reality for the life that person likely has, or else you can't orchestrate that. So a long answer, but you're right. I've thought a lot about it, and I've tried to incorporate the thinking into each of the roles I've played in the last decade.
I've been meeting with more community health centers in the work that I'm doing right now, and the feedback I get from the doctors and the nurse practitioners, the providers, is that Faisel, we hardly have enough time right now as it is. They're still struggling with maybe 2 visits per patient per year. And so I'm seeing AI taking more of the heavy lifting in my day-to-day life. How do you see AI impacting the daily lives of primary care doctors in these very challenging work environments? And their goal is like, hey, I just want to spend more time with the patients.
I think you just nailed the driving force behind this, at least the product I'm working on right now, and there'll be others in the market, right? Which is the role of care team member takes on several personas. It's care coordinator, it's health coach, it's chronic disease navigator. It's all of these ancillary service roles that in an idealized world, the care, each primary care doctor would be surrounded by this giant care team that would take work off of the doc. Well, the reality is we can't afford that, and it doesn't happen. AI can do that. And so I do see conversational AI. And again, that could be through text. It could be through a conversation. I see that being the answer here. I really do. I think, you'll still need humans because there will be a limit during a conversation around dealing with a transportation barrier. The patient is going to have that moment where they say, oh, by the way, why I have you, I have this, I've had this weird headache for the last 2 days and I'm not sure exactly what to do. And so AI will either have to kind of then shift to a triage tool or have to hand that off to a human. But those humans can be scaled across much larger populations if the day-to-day interaction with patients is happening with AI. So I don't think there's a human solution to the problem you said, Faisel. In our lifetime, I don't think we'll solve this by throwing more people at it. We're already subsidizing primary care in health systems to the tune of $250,000 per physician. So, adding people to that problem makes that a $300,000 to $400,000, $500,000 problem. And I just think we're just going to run out of resources to do that. When we talk about the problem in primary care, we've tried to frame it in a way where we can talk about it really easily. So we think there's like 500 million hours of primary care delivered in this country a year right now. We think we need 2 billion more hours to take care of the 100 million people who don't have access to any primary care and to deliver really high quality care, primary care to the people who do. It's like 5x what we have today. And it would cost about $1 trillion to solve that with the current kind of workforce approach to that. So we just know that's not going to happen. So it screams for technology. And I think we're lucky to be in a world and at a time where we do now have technologies that actually can take that on. So I'm actually kind of excited about that because I've tried every which way to solve this with people, and I just don't think it's solvable.
Are you seeing a way to do health behavior change using AI? I mean, it's one thing. I think it was a term I learned from. I think the first time I heard it was from Gordon Chin, is coaching for health rather than consulting for sickness. And so it's one thing to know that somebody needs their shingles vaccine, their COVID vaccine, pneumococcal vaccine, and it's a whole other thing to get them to actually agree to take the immunization. And that's where it does take a little bit of time. And that's where a lot of those hours need to be spent. Do you see AI being able to do that piece of it?
Yes. In fact, that's the earliest use case is that because it's low risk. So to your point, today what happens, right? I need a shingles vaccine. There's an alert that's been in my my chart account for 5 months. So I mean, the doctor says, well, I told Dr. Carmouche he needs to have a shingles vaccine. Well, I haven't done anything. Instead, had I had a conversation about shingles, answered question, maybe the chat bot. I hate to call them chat bots because that really actually isn't what they are. But if the AI agent was able to converse with me, talk to me about shingles, what debilitating symptoms are that'll happen, how safe the vaccine is, where I can get it, whether I'm going to have to pay for it out of pocket or not. If I could have had that conversation and then also maybe be told like where's the closest place to go get it, I probably would have done it by now. So yeah, I think that's all very doable with AI. And I have my own personal experience here, Dan, that you guys have interacted with other physicians. Physicians who are, held accountable to whether it's a quality metric or some outcome will always say, why don't you hold the patients accountable? To create accountability at the patient level. Like, hey, and this was really prevalent when I was at Blue Cross and I was the chief medical officer there. And they were like, look, you need to build into your benefit structure something that creates accountability at the patient level. You're holding me accountable. Well, in my practice, I was a preventive cardiologist, and one of the most common referrals I got was statin intolerance. So patients who had vascular events, had stents, revascularization, and couldn't take a statin. And we kept a registry of these folks, and just over 80% of them that I saw and my team saw, we were able to get to take a statin. And it's not because we had different drugs or a magic wand. What we did was we actually sat down and explained what atherosclerosis is, and we actually talked about how the drug works. And we made them understand that if you had cancer, if you had a blood cancer and you had to take a pill called atorvastatin every day to keep that blood cancer at bay, and there was a small chance that it was going to cause some muscle aches, would you take it? And they're like, well, yeah, of course, it's cancer. I said, okay, you've had 2 heart attacks and 3 stents. That's your cancer. Oh. And I'd show them a picture of what a plaque looks like. And you'd show them and so for me, a lot of patient engagement is just the provider, and I'm going to say care teams, not just the physicians, haven't done a good job at figuring out how to change people's behaviors, right? Behavioral economics. And partly it's because they've been forced into 7 to 8 minute office visits, and it's hard to do this without taking time. So what I had to give up was seeing 30 patients a day to see 16 people, but get them to do the right things and live a healthier life. I think AI allows us to do a lot of this without having to give up as much. So I think that's the difference. And I think that's going to be a key role of technology.
It'll be interesting after we do this, not today, but sometime in the future. Dr. Carmouche gets off of this podcast interview and he's scrolling on his Facebook and he starts seeing all these horrible complications from shingles popping up on his feed, and he'll say, you know what, I better, not knowing that he's probably being geotargeted.
Yeah, and in today's world, I'm not sure if I'm supposed to be pro-vaccine or not. So I just don't know what's going to happen on the other end of this.
No, but that may well happen. I mean, that's the thing about it is Facebook and Siri and all those, they're so much further ahead, and they're suggesting what beer to buy or what restaurant to go to. It would be great if it was suggesting which statin I should be taking, right? I have problems with the atorvastatin. Well, 90% of the people who have problems with atorvastatin take rosuvastatin without a problem. So, or maybe we try a lower dose or something like that. So it would do that. That'd be pretty cool.
The current system revolves so much around the chief complaint, regardless of whatever it is, right? The doctors are so busy, and then they're stuck on the back pain or the finger pain or whatever, rather than what's really concerning us that'll make the person, that the person's going to end up going down the path of going to the hospital. But I feel like from what I'm hearing, Dr. Carmouche says that there's a lot of passive listening here. Like the magic that happens, it's not with the chief complaint. It's never with the chief complaint. The chief complaint is like, okay, that's what we did, and usually it's in between the chief complaint and oh, by the way.
So it's great. We give lip service to this notion of whole person care, right? But yet that care is chopped up into a bunch of chief complaint driven encounters, and we never get to that whole person care. And I think that whole person care is actually the key to health, right? So solving your finger problem today is a key to getting you out of pain, but keeping you healthy is taking care of you all the time. And I think that's the interesting thing about AI and AI agents is they're 365 days a year, 24/7, always on. They can have an encounter with you at 11 o'clock at night if that's you're most amenable to receiving a healthcare conversation, right? So I just think I do believe this is going to change fundamentally how we design care. And I think it's going to be for the better. I think everything we are talking about right now will be part of, and we will probably look back not too far into the future as to how we practiced primary care, a decade ago. And we'll be like, that was so barbaric. Like, what were we doing? I think it's going to be that different.
We can never be progressive enough, right?
I honestly feel like in some ways, I have gone through a time warp using ambient AI to do my office notes. I mean, I'm back to sitting down and talking to the patient. I'm not sitting there pecking away at the computer. I mean, yeah, I still have to enter some orders, but I used to have to fill out forms. But now it really is about listening to them, talking to them, thinking about what next question I should be asking instead of what's the next template I should bring up with the list of questions I should be asking.
Most of us who went into primary care, that's what we wanted to do, right? I mean, you don't do primary care just to run patient to patient to patient and barely have time to sit down. I mean, that's just not who we are. And so it's just great to hear. So I do believe like that technology experience for you, Dan, to me gives me hope that AI will be adopted by providers, assuming that they can see now. I think the big thing here is going to be, and I'm really am worried about this in the first year or two of AI, is that the way we have to set guardrails for how far AI can go causes AI to bump up against a guardrail fairly quickly. And if the default is, I'll notify your care team, then I'm going to create a tsunami of in-basket messages. And I think providers have said in-basket has been probably one of their kind of biggest banes, right, with the EMR. So we're going to have to, we need to move quickly to allow AI to resolve some things, because if everything just comes back to the physician and you're having thousands of conversations at the same time, creating lots of insights that have to now go back to the care team, if those funnel to the physician, I don't know that we will have helped. So I do want to think carefully about how we design and deploy AI so that we don't inadvertently create a problem early on that then precludes us from getting to the true value later. And I think we have to get that right.
Yeah, thinking about where the constraint is, or we need it to help us take out the garbage, not tell us the trash can's full.
Exactly. That's great. Perfect.
Well, Dr. Carmouche, now we've got a new political landscape and a lot of changes. My gosh, I mean, every day I'm just seeing changes and just fast changes. But in particular with healthcare, like what do you foresee with especially around funding and the future of primary care?
Oh, wow. It's a mixed bag, right? Because on the one hand, you hear commentary from Mehmet Oz, who I assume will get approved as to lead CMS, and RFK Jr. about the value of primary care and this promise for primary care funding and support. And so there's that, which is a positive message. But then today, I think I just saw like Medicaid is targeted for massive cuts. And so like there's these mixed messages, right? Well, we're going to support primary care, but now access to primary, or the funding mechanisms for patients to access that primary care are unclear to me. So I don't know. I hope that folks rally around the notion that we need support for primary care, and we need to make sure that patients can access that primary care. And if you do one without the other, I don't think we're going to have created value. I think the value-based care movement, which I believe took a couple steps back post-COVID, I think my sense was health systems got very focused on refilling specialist offices, refilling their ASCs, refilling their hospitals in some ways with better case mix than what they had during COVID. I think value-based care, I believe, will become a bigger part of the story over the next few years of this administration. I don't know if that's going to play out just in Medicare Advantage policies, which have kind of been on the front line of value-based care from a payment model perspective. We'll see what happens post ACO REACH model expiring. Do we replace that with something that's similar or even more ambitious? I think the biggest problem, though, for me, that has been the biggest challenge to value-based care adoption is that the commercial payment models haven't really followed as much as I'd like. And largely it's because there's been a big movement to move from fully insured to self-funded, and the brokers have promised employers that move will create savings. Those savings will accrue to them. And I think what they miss in that is that the payment model does matter, and how you incentivize providers does matter. And I think that it's too fragmented, and we haven't figured out a solution. And so what we've done is we've created this kind of two-tiered payment model where you've got a sliver of your panels in value, you've got another sliver that's in fee for service, and therefore you really don't change your operating model. You kind of run back and forth in the schizophrenic world, and that's kind of stymied us. So what I'd like to see is the commercial worlds coalesce around a value-based care model, even if it's just in support of primary care. If it's too hard to do that at the hospital level or at the subspecialty level, let's do it for primary care. Can we have demonstrations in states or in communities where multiple payers align around a single payment model for primary care? I think that would go a long way to setting up the environment for full-scale innovation transformation that collectively might show the rest of the nation how this can be done. So I hope that we see support for initiatives like that, and so for now, I'm optimistic.
It makes me feel much better. I have one last question for you. I mean, I have a lot of things I want to talk to you about. Thank God we're not sitting together over a cup of coffee, because I would be going for a lot longer. My dad was he worked at AT&T Bell Labs. He was an inventor, and I got to spend a lot of time around all these great inventors with caller ID, voice recognition, flash memory. It was amazing going in there. And I remember as a child just seeing all these things that it was stuff that I thought was science fiction. And now you're in Lumeris, and I know you can't talk about all the fun stuff, but I'm sure there must be something, because I'm seeing it right now with AI. Like, it's amazing. There's so many things that on a daily basis, like, wow, I cannot believe, like Dr. Dan said, like, there's no way once you get exposed to it, you're like, can't believe you can't go back to the way it was before. But when you first went in there, and what was like that one gem that you saw that you're like, oh my God, I didn't expect this, and probably most doctors.
So this is an awesome question, and I've got an awesome answer for you. So I got to Lumeris, and I didn't go there because I thought I was going to be playing in the AI space. I went there because they were trying to partner with health systems, which are really hard partners, by the way, really complicated partners, to be a risk-bearing operating partner for those health systems, to bring them down a value-based care journey. And I just believe that's a reasonable way to go at it, because health systems have gobbled up half of the primary care in the country. So if you're going to do primary care transformation, doing value-based care at health systems would be a good way to get to primary care transformation. So that was my mindset going in. When I got there, one of the first meetings, as I was kicking the tires of the technology that had been built to the tune of like $400+ million, cloud-based, modern architecture to take a health system's multi-EMR, multi-payer, multi-other source data and aggregate it and normalize it and cleanse it and make it available for our analytics, I recognize like that's the basis for like launching AI. I mean, like that part of the problem is that health systems data is on premises, it's not in the cloud, and it's going to have to be moved to the cloud, and it's going to have to be cleansed to be able to be the substrate for AI. We had that. And so then I was like, well, now once you have that, not only can you build AI on top of that, you can launch that AI with an understanding of what a person needs, because you have access to their longitudinal health record. And so now it's not point solutions. Now it's predicting the next best action to keep someone healthy and automatizing that, right? Automating that. So what was the aha moment, though, was to actually experience AI for the first time. And let me tell you what I did. So we named the product that we're building Tom. It's named after Tom Dorr. Tom Dorr was an internal medicine physician in St. Louis and was the founder of Lumeris. Tom died tragically, unexpectedly 5 years ago. His wife gave us access to synthesize his voice. We created our first AI version of Tom using Tom Dorr's voice. And when we played it for the first time to our board, his brother, John Dorr, world-renowned venture capitalist, founder of Kleiner Perkins out in Silicon Valley, and who's the major funder for Lumeris, was listening to his brother talk to me for the first time in 5 years, and he started crying. So for me, like, it was in that moment where I was like, holy cow, this is so realistic and so human-like. And if it can be powered with really world-class information and knowledge, what a power for good. And from that moment, I told Lumeris, your solution now isn't constrained by value-based care at health systems. Your opportunity is to solve primary care in this country and frankly around the world. And so that's actually the evolution of the Lumeris work. And it's moved so quickly now because technology is there, it's ready, and now it's just a matter of just deploying it with partners and learning how to do this fairly quickly. So that long answer, but man, it hit me like a ton of bricks, Faisel.
Wow. Dr. Carmouche, Thank you. Thank you so much for taking the time out to come talk with us. We got to take this show on the road, Dr. Dan. This would not have stopped right now. Actually, we probably would
maybe
have
I'll come back in a few months and give you an update, because it's an exciting time. And the good news is the early partners that we've approached to try to kind of get into this with us are super excited. And what's really positive for me is how kind of ubiquitous the problem is understood. How many people understand this problem that primary care faces, and how hopeful they all are that technology can play a role. So look forward to updating you guys along the way and learning together.
Wow, there you have it. Thank you so much, Dr. Carmouche.
Good to see you. Thanks for having me.
What are your thoughts on Compassion in Code, leveraging technology for personalized patient care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.